this one is.
Okay, so you're on. Okay. All right, we're going to get started and see what happens. So Tonjeh is a fourth year Peds resident, and this is her Grand Rounds presentation. And she picked a really good topic, especially for a Med-Peds person, because we have a lot of children with chronic diseases that need to transition from pediatric care to adult care. And this is a really important subject and an opportunity to make things go right when very often there are problems in making the transition that make the patient have some real problems. So looking forward to the presentation. So Tonjeh.
Thank you. So today we'll be talking about transition. I have no relationships or financial attachments to disclose relevant to the content of this presentation. For our objectives, we'll define healthcare transition. We'll discuss the importance of transitioning adolescents to adult healthcare. We'll talk about some relevant articles pertaining to healthcare transition. We'll explore various obstacles and discuss some modules in place to help with this transition process. At the end of the talk, we will talk about the healthcare transition program here at our center. We have a huge sickle cell population and what our plans are for the future. Doland Medical Dictionary defines transition as the passage or change from one state or condition to another. Other words that have been used in the place of transition are handover, transformation, conversion. When I think of handing over something, I think of giving up responsibility, passing it on to someone else. So if I hand over care to another resident, I've given up that opportunity of making medical decisions. So I may still see that patient around, but I'm not in charge of making decisions on that patient again. Each and everyone in this room has been through some kind of transition, starting kindergarten, going off to college, starting a relationship, and relocating. I'd like to share with you one of my many transitions. I was born in Cameroon in a very close-knit Catholic family. We all went to Catholic boarding schools. Every trip we made, it was with the family. And I'm the first girl. There's always something with parents, fathers, and their first girls. So my father was always very protective. When I graduated from college at home, I got a visa to come to the United States. This would be my first trip without my parent. I was worried, I was worried about so many things. Will they understand me? I have an accent, so many things, but my father was more worried than I was. He thought I wasn't ready to face the world. He thought I would not stand up for myself. There were so many things that were going on. And my transition to college had its thorns and roses. It wasn't an easy one, especially the first 2 years were not really easy. Now I am happy that I made that decision, overcoming my fears and coming here because I was able to do the things I've always wanted to do. Today, though, we'll be talking about a special kind of transition, not just our usual life transitions. We'll be talking about transitioning adolescents with chronic medical condition into adult health care. The AAP for content guideline expects everyone involved in pediatric care to be able to provide appropriate guidance to transition adolescents from pediatric to adult health care. In the July edition of the Journal of Adolescent Health in 1995, Blum and colleagues defined healthcare transition as the purposeful, planned movement of adolescents and young adults with chronic illnesses from child-centered to adult-oriented healthcare. Healthcare transition in itself is a very broad field. It involves social, career, vocational, and medical transition. Today, we'll focus only on the medical transition part. According to the AAP, healthcare transition process is put in place to ensure high-quality, developmentally appropriate healthcare services in an uninterrupted manner as patients move from adolescence to adulthood. So the goal of transition in itself is to optimize health and assist the youth in reaching their full potential. Why is transition even necessary? With the advances in technology and medical care, many children with chronic diseases are now living into adulthood. According to the population survey in 2013 by the U.S. Census Bureau, 18 million adolescents ages 18 to 21 will be transitioning to adult health care. And out of this 18 million, 25% of them have chronic medical conditions. To support the fact that these patients now live longer than before, the life expectancy of a CF patient today is 45. In 1966, it was just 10.6. And a child born with CF today is expected to live into their 6th decade. And it's the same thing follows with sickle cell. The median age of death for a male with sickle cell type SS is 42 today. And with females, it is 48. A patient born with SC, the median age of death for male is 60. And for women is 68. And there is an expected 50% of sickle cell patients are expected to survive into their 5th decade. The challenge with this, though, is the longer they live, the more complex their disease gets. The American Academy of Pediatrics, in their clinical report that was published in 2011, stated optimal health care is achieved when every person at every age receives health care that is medically and developmentally appropriate. The main difference between child and adult health care settings is the amount of independence these patients gain. With independence comes the need to learn about their condition, speak up about any concerns they have, and seek advice when they need it. So it's not just a physiologic change. There is an expected growth with that, and we want them to reach their full potential. What are some of the challenges going through the transition process? These are things the patients have said from the patient's point of view. They say they already know their pediatrician. They don't want to move. They don't want to move on to someone else. And something is, our patients think we know it all. You know, when they come in, they think, you know, you've been taking care of me, you can take care of me till I die. But it's really not the case. We have to make them understand that, you know, as you're getting older, things are getting more complex. Some of them say, we'll form a tight bond. We are already family. We don't want to break that bond. Some of the things my patients told me is, Dr. Bah, they don't even know me. You know, what if the nurses are not as nice? Actually, I've heard the nurses on medicine are not as nice. I hear the doctors are too busy for me. I'd like to share with you a story with one of my patients in my continuity clinic, Evelyn. Evelyn is a 7-year-old Hispanic female. She has asthma. During my intern year, towards the end of my intern year, while I was in the ER, she came in for exacerbation. And then when I went through her chart, she wasn't in a continuity clinic. I decided to steal her into my clinic. So on average, I see her 3 to 4 times a year. And every time in my clinic, we have a routine. So we have books you read with pediatric patients when they come in. So Evelyn knows when she comes in, we read a book, and then she tells me what has been going on with her. Her mother doesn't talk yet. And then when Evelyn is done talking, her mother tells me what Evelyn has forgotten. We play doctor, you know, I listen to her. Sometimes she wants to listen to me too. And then we come up with a plan. I saw Evelyn last month. No, a month and a half ago when we were done with our routine. I told her, Evelyn, you'll come back in 3 months, but you'll see a new doctor. And Evelyn looked at me and thought something was wrong. I said, yes, I'm graduating. You meet this nice doctor. She's one of the best doctors in our clinic. She just burst out crying. She's like, no, Dr. Bah, I want you to stay. And I felt really bad, sorry, because I didn't prepare her for this. I waited for an appointment, you know, for one of her visits, and I said, you're seeing someone else. You know, if Evelyn has a hard time accepting this transition, you know, what more of patients who have followed their pediatricians or their specialists for the past 18 years? It will be much harder. So in 2002, a team of physicians from the American Academy of Pediatrics, American Academy of Family Physicians, and the American College of Physicians published a consensus document which called for the critical first steps to improve the transition process. This consensus document has now been approved as policy for the process. This team of leading physicians noted that without a coordinated transition plan, young adults were without a medical home, leading to delay in health care and many of them seeking care in the emergency room. They also noted an increased mortality in these patients during the transition process. So in the next few slides, we'll go through the 6 consensus statements. The first consensus is to ensure that all young people with special healthcare needs have an identified healthcare professional who not only attends to the unique challenges of transition, but also assumes responsibility for current healthcare, care coordination, and future healthcare planning. This responsibility is executed in partnership with both the adult and the pediatric patients and their family. It is intended to make sure that as transition occurs, all young people have uninterrupted, comprehensive, and accessible care within their community. Our second consensus is to identify the core knowledge and skills required to provide developmentally appropriate healthcare transition services and make them part of training and certification requirements for primary care residents and physicians. So the second consensus mandates some form of training in place for us physicians to be ready to receive these patients when they are transitioned to us, to be ready to take care of their complex medical conditions. The third consensus, which is a very critical one in a successful transition, is to prepare and maintain an up-to-date medical summary that is portable and accessible. We do this in a small scale here on our inpatient, like when we have a patient, every note has like a clinical summary. That is supposed to be something that, you know, if another physician gets in that chart and they read that summary, they'll know everything that has happened. I mean the important, the pertinent things. Just imagine us doing it just for, you know, someone who is on the floor for 3 days. This team of physicians, they want us to do it for every patient. We are getting ready to transition so that if I'm taking over a patient from a pediatrician, I can just read this one page and I'll know everything that has happened in their life. Or they had a stroke at this age, this is what we did, they had avascular necrosis, little things like that. So this is very critical in the transition process. The fourth consensus is to create a written healthcare transition plan, which includes the services they will need, who will provide these services, and how they'll be financed. And this should be done by age 14. By age 14, not age 18 or 19. And usually this plan has to be reviewed and updated every year and whenever there is transfer of care. The fifth consensus is to apply the same guidelines of primary and preventive care for all adolescents and young adults, keeping in mind that young people with special needs or with chronic medical conditions may require more preventative measures when compared to their healthier peers. The sixth and the last consensus statement is to ensure affordable, continuous health insurance coverage for all young people with special health care needs throughout adolescence and adulthood. So all the consensus statements involve some kind of planning. A well-planned transition makes the process so much easier and less stressful. Let's now go through some surveys and articles pertaining to healthcare transition. So we've had multiple small and large scale surveys of healthcare providers, which have consistently shown that they lack a systematic way to provide transition support from pediatric to adult health care. 3 years after the consensus statements were published, Rice and colleague, they published an article in Pediatrics, and the title was Healthcare Transition, Youth, Family, and Provider Perspective. Their survey was based on 2 questions. What were the obstacles to healthcare transition, and what were the practices that made it easier, made a successful transition? Some of the obstacles were the adult physicians were reluctant to accept patients with poor cognitive ability and the patients with progressive disabling diseases. And another obstacle was there was reluctance on the part of the patients, family, and even the providers to do the transition process. As for the things that made the transition process smoother, physicians felt it was much easier when the patients were educated about their diseases, when they knew what they had, the medications they took. And then also it was easier when the process was started earlier. It was much easier when they had a team that was involved. that was involved in the transition process. So 4 years later, after this article was published, in the same journal, Peter and his colleagues, they published another article. They said, okay, let's, the title was Transition to Pediatric Care, the Internist Perspective. The goal was to understand the challenges encountered by adult healthcare providers during the transition process. And so they performed a two-stage study that was conducted from August 2001 to November 2004. And in stage one, they wanted a group of providers to list what their concerns were. Stage two, a different group of providers were asked to rank those concerns. So for going back to the stage one, they had 134 randomly selected adult providers who were eligible to do the survey. And 67 of them turned in, completed the survey. And some of the categories they felt were, some of their concerns were patient maturity. They felt these patients do not even know what's going on. I can't take care of them. And then their psychosocial needs. Most of them needed a lot. It's not just come in and go out. You have to spend so much time with them. And sometimes that time you don't even get paid for it. And then another thing, they needed family involvement. Sometimes they pass on these patients with chronic diseases and the families disappear. They are not even there. Imagine our sickler coming in, they don't even know what medicines they are taking, And then they also felt they needed a transition team. And then the second stage of their survey, they had 112 adult physicians who were eligible, but they got 65 response back. And what they concluded, based on those responses, their conclusions were the intern is clearly stated they need more training. They are not ready to see these patients. We think they know it all, but they need special training to be able to handle this. And then also they felt they needed more adult subspecialties who will take care of these patients. We are transitioning them, but they have a long wait time before they see a specialist because we don't have enough of them. And then they also felt that continued family involvement was also important. So in 2011, after all that was done, the same team of physicians who did the 6 consensus statement decided, let's come together and bring out the clinical report. They felt it was time to make things easier. And the goal was really to break down those 6 consensus statements into simpler, practical terms. The clinical report represented expert opinion and consensus on how to facilitate the transition process, beginning early in adolescence and completing it ideally between 18 and 21 years. So they emphasized on the importance of having a planned transition process and with the goal to maximize lifelong function and well-being of the patient. In the clinical report, they discussed some obstacles we've already talked about earlier, and some of them were lack of a transition team, lack of trained experts to handle special needs, lack of patient education about their disease. Patients were ill-prepared for the change, and then loss of insurance and stereotypes. Recently, during our health fair here on campus, Dr. Mansour, he's the adult hematologist, we were just talking about healthcare transition. And he said, Tonjeh, one of our problems is just the stereotype that goes around, We were talking and then they called him away, so we really didn't finish our conversation. But this really stuck, like every day I think about it. And I think about a sickle cell, and he said, imagine a sickler coming to the ER in pain crisis with dreadlocks. In my mind, this thing has played through my mind almost every day. I was like, what if they have dreads and they have tattoos all over and they come in sickle cell pain crisis or acute chest syndrome? Their chances of dying is very high. Because when we walk in, we look at them, we're like, oh, he's drug seeking. The stereotypes that we've made, And sometimes even in the ER, the adults, they'll call you and say, hey, Dr. Bah, we have a patient, he's a frequent flyer. A frequent flyer does not tell you anything. There are several things. What do they have? Are they, are they having a stroke, or is it a frequent flare? So certain things prevent us from really looking at the patient, looking at what has really brought them here. And then one of the things that is also causing a huge trouble is the strict opioid rule that was passed by the government. So recently, many people have had problems with, prescribing narcotics. And now many adult physicians are scared to take patients on chronic opioids because they don't want to lose their license. So there are several things that is, not helping with the transition process. The gut transition team, which we'll talk about later, summarized the clinical report in this table. So starting, letting the patients know about the process at about 12 years old, and then by 14, we have a transition process. You have a document, you have a plan that is written. At 16, you prepare them. There are several ways to prepare them. You educate them. You let them visit the adult healthcare, the adult section, see what it is, so that by 18, you're ready to make that transition. And then by 18 to 22, they expect that that the transition process should be completed. And later on, we'll talk about, the transition process is unique for every patient. Some of them are ready by 16, and then we have some who are not even ready at 21, So 3 years after the clinical report was published, an article surfaced in the Wall Street Journal by Laura Landreau. She does some of the health topics in the Wall Street Journal, and her title was "The Challenges After Surviving a Childhood Illness." We should think, oh, my child has made it, we should be happy, things are better for us, but they have more challenges. In this article, she talked about 3 stories. The first one was a 23-year-old neurosurgery patient. She had had multiple surgeries, and now she was going to transition to adult healthcare. And the internist was like, oh no, I can't take you. What if you come in with a headache and you're having something else, not just a headache, And so it took her a long time to find someone to get her to accept her. The next case she talked about was a 21-year-old patient with diabetes type 1. During her transition process, she lost her insurance. She was under her parents, and now she doesn't have insurance. She ended up those few months spending so much time in the ER with DKA because she couldn't afford her insulin. And then the third case she talked about was a 23-year-old severely disabled cerebral palsy patient. The internist was like, oh no, I don't know what to do. I'm not trained enough to take care of a CF patient. And this patient went through, was rejected by several physicians. So it's really, they go through so many challenges. So finding a physician who will accept patients with chronic medical conditions is an ongoing struggle. The medical director of Christiana Healthcare Transition Program says. And she thinks, though, that the main problem is because our adult physicians are not trained enough to take care of these patients. And also in the same article in the Wall Street Journal, the writer talks about transition process being a challenge for both, the patients and the physician. So it's not just the patients, but the pediatricians also have a hard time letting go and also finding the care these patients need. So she concluded that to achieve this goal of a fluid transition requires an organized transition process to support youth in gaining independent healthcare skills and preparing for adult model of care and then transferring to new providers without disruption of care. We really need to, so the goal is making sure that we have this transition without a break, because it's during that break that many, problems happen. So what are some of the organizations that have surfaced to help with this transition process? Right around the time when the clinical report was published, many organizations were formed to help promote and assist with the transition process. So God Transitions is one, and it's a big group, and it's just a group of physicians that help other hospitals with the transition process. A few months ago, we had Dr. Jane Hankins from St. Jude's Children's Hospital. She came and talked to us about their transition, their healthcare transition program. I went to their website, and they are a big program right now. And they are big on educating their patients, letting them know what their disease is to help them, integrate well. And what all these, there are several other programs out there. Recently, I found the Tulane Medical Center Transition Program, thanks to Ms. Jackie. And so what all these programs do, though, is they put into practice the consensus statement and the clinical report we talked about earlier. God Transitions emphasizes on the need of an organized transition process without disruption of care. So it's a process that should be started earlier. The team, let me see. So the transition process is a continuum rather than just an event. And what the team's God Transition said was, let's follow the guidelines of the AAP. So we start at age 12, and especially by age 14, every patient should have a transition program. And this allows for the patient and their family to plan for their future healthcare with their health team, to go around, to have enough time to look for the different physicians who will be ready to take care of them. I got this summary table from the God Transition website, and I think one of the things that I really like about this is this last step that we haven't talked about yet. So what it says is, you do not only transition the patient and you let them go, you make sure they are fully integrated. When you see that they are, they are fully integrated in the adult healthcare, then you end the transition process. So God Transition teams, they have 3 categories of patients they work with. So like I said, it's a big organization that helps patients and other hospitals, with the transition process. One thing, you can go on their website and you type in the information of the patient you want to transition, how old they are, what their condition is, and they generate something for you. So they deal with 3 different categories of patients. They are looking at patients who are transitioning to adulthood and changing doctors. That's patients moving from a pediatrician to an adult healthcare provider. And then they also deal with patients who are not changing providers. These are pediatric patients who have been followed by a family healthcare or a med-peds physician. But what they do is they're transitioning into an adult approach. So as they get older, you don't keep doing the same thing. Your practice, your approach with them changes at some point. And then the last group of patients they deal with are those who have already gone through the transition process, but they need integration into adulthood. So when God Transition was created, they proposed 6 core elements and did a trial run that was conducted between 2010 and 2012 in the northeastern states of the US. And the purpose of this was to see if these 6 core elements were feasible and would result in an improvement in the transition process. So based on what they did is, while the pediatricians were working on transitioning the patients to adult care, the adult care is also working on receiving this new patient and getting them integrated into their system. So while the pediatric group, they have their youth registry, the adult care, they also have a registry for the patients who will be coming in, to them. And then while they are planning, while the pediatricians are planning the adult care, they are also planning to receive them. So after 2 years of their survey, after this 2-year trial run, they found out if it's feasible to implement the 6 core elements, involving both the pediatricians and the adult practitioners right from the onset made it so much easier. And then also getting the family involved was one of the things that made the transition process easier. And then one of the things they talked about was they need to consider these young adults as a special population in adult practice. So you don't just throw them in there and expect them to be adults in a day. You still have to gradually get them to where they need to be. When I read this need to consider the young adults as a special population, I thought of a patient. So I was an inpatient about 2 months ago, and we had a sickle cell patient come in, pre-admission for a TNA the next day. I put in the orders. So he was admitted on the Peds service. I put in the orders, but he had to go to the adult floor. I think what they're doing now, if you're 17 and older, they put you on the adult floor, or especially when we do not have a bed. So after I had done the orders, like 30 minutes or an hour later, I got a page, and they were like, Dr. Bah, we need you here. We have a problem. When I went upstairs to the 6th floor. This patient and his father, they were sitting in the waiting area. And when I went to talk to them, I was like, what's the problem? They were like, oh, no. So unfortunately, this boy was roomed in with a 70-year-old altered mental status. So when he walked in, this man started talking to him, and he went right out. And he was so scared. He said, no, I cannot do this. So he was ready to get his blood drawn in the hallway. I mean, they didn't want to go into the room, and I told the nurse it was okay. Go ahead and draw the blood. I will talk with the people. So really, we did blood draw in the waiting area, you know, like right next to the nurse's station. And I called the house supervisor, and I was like, please, I need help. You know, the house supervisor and bedding control, and what they did, they had to move patients around. And he was finally roomed in with someone who was about 30-year-old, and thank God it was another sickle cell patient. But these are the things we should really keep in mind, you know. We are trying to get them to the adult healthcare, but they are still not ready. So they need special consideration. So let's conclude talking about the transition process of sickle cell patients here at our center, since we have a huge sickle cell population. I found this picture in the sickle cell website. So the boy in the middle is an older brother to those twins. He's 15 years old. Those twins were born with sickle cell. He doesn't have sickle cell. What he did was he did a bone marrow donation, one for the older twin, and then he was cured, and then he decided to come the second time and do it for the other ones. So they are now healthy and growing together. So we'll talk about healthcare transition of sickle cell patients here at our facility. So just before we talk about it, it's a little bit of repetition, but 90% of children with sickle cell now reach the age of 21, and majority of them are expected to live into their 50s. This is thanks to medical advances of antibiotic prophylaxis, immunizations, and then the disease-modifying therapies like hydroxyurea, chronic blood transfusions, and there is a lot going on right now. They are working on drugs that target cell adhesion and inflammation. So in the future, sickle cell will not be what we are seeing today. The problem, though, they are living longer, but the problem we are facing is that there is increased mortality after the age of 18, which is when they are being transitioned to adult care. And right soon after the transition process, with a mean time of 1.8 years following transition. So within 2 years of transition, many of them die. And for this reason, securing successful transition from pediatric to adult healthcare becomes essential to maintain continuity of service and appropriate disease management for the patients. So the challenges faced by these patients with sickle cell is the same. It's similar to what other patients with chronic medical conditions face. So here at our center, we have a small-scale transition program. We have Miss Jackie, who is our coordinator, and she's here with us. She's sitting somewhere in the back. And she works with Dr. Jerudi, our pediatric hematologist, and then with Dr. Mansour. The team is Dr. Pediatric, adult, and Miss Jackie. And what they do is they try to transition between the ages of 18 and 19. And Miss Jackie would go to the pediatric clinic and visit with them. And then sometimes Dr. Jerudi will call, hey, I have someone, I'm ready to transition, I want you to come and see. So what she does is she goes down to the clinic, she brings them up. So the ped hematologist is on the first floor of the Weisweiler, and then adult is on the second floor, second and up. So Miss Jackie would see those patients, give them the new patient folder that has everything, information about their disease, how to take care of their crisis, relevant contact information, and things that they need, and all the way to sexuality, So she brings them up, she shows them around, and then she makes she schedules the first meeting with the adult healthcare, with the adult providers. So she does this first meeting, but they still have, they still keep some of the appointments with the pediatric hematology and oncologist. The problem though is Miss Jackie told me they had maybe 2 patients. After their visit with the adult healthcare, they went back to Peds and didn't want to come back. I mean, it's your first visit. You don't know them yet, you know. So they felt, oh well, I don't think I like it. So, but it's a process. We are working on it. What are some of the projects in place? So we have a sickle cell support group for adults here. They meet every Monday. And Miss Jackie said, when they come, we meet. When they don't come, you know, and they have someone who is 68 years old, you know, who still comes to the thing. Miss Jackie tried a teen support group for the summer for patients between 13 and 19, but it wasn't successful. They just did not show up. So she's trying to find ways, you know, to get our young sickle cell patients involved. Currently, there's a survey going on, and this survey is for their caregivers to find out what are the things she can do to get these adults so that by the time, you know, they're getting into 16, 17, they already know Miss Jackie, they already know the adult care. It will be easier to transition. And then in our Peds clinic also, we are working on educating the sickle cell patients when they come in. Our problem is these sickle cell patients do not come to us. They go to Dr. Girudi for everything. When I was on Peds hematology, on Peds hemong, we were giving them their shots there because we know if we don't, they will not come to the adult, they will not come to the Peds clinic. So it's really hard, it is challenging. And then our child life department, they have a coloring book and activity book to help our sicklers learn about their diseases, just to empower them, give them the tools they need. And then what are the plans we have for the future? Our plan is to enroll the new patients enroll the patients in the hemong fellows clinic. One of the things Ms. Jack is thinking of doing is transition these patients to the new fellows, just like we have our continuity clinic. So when I start my fellowship, every sickle cell patient I'll have my first year, I'll take them through until my 3rd year. So that will give them some form of, you know, comfort. They know me, you know, they know who I am, and we will work together. And then there are plans to start the transition process earlier, which will make it easier rather than calling when they are 19 to say, I'm ready to transition. And then also one thing Ms. Jackie said that I really like was have a ceremony at the end, like a graduation. You know, you've graduated, you've completed your transition process, to give them something they'll look forward to. And then to conclude our talk, healthcare transition is a process over several years, ideally starting between 12 and 14 and completing at 18 to 21. The transition requires participation of both the pediatric and adult healthcare. And then adult physicians have felt the need to gain more training in order to provide the care these patients need. And there is a lot that's going on right now. We have CME activities for us to do, you know, to help prepare us to take care of these patients. And then educating the patients about their diseases and the complication makes it less stressful and easier as they grow older. And then healthcare transition process is feasible. It is for the benefit of everyone involved in the patient's care and for the patient's greater good. So here are my references. Thank you so much for your attention. We welcome comments and questions.
Very nice. Questions?
I think this is a terribly important problem, and it's very difficult. And I was wondering, do you have any considerations here been given that certain common chronic diseases, that not all chronic diseases require a lot of care? Has any thought been given to maybe starting an adolescent clinic for these problems? And then you would have maybe internists, pediatricians, and the other appropriate people, where they would be in this integrated section where the doctors are going to rub elbows and get some consensus on how to handle these problems. And the patients feeling comfortable seeing both groups of them. I wonder if that is something we ought to consider more seriously.
You know, that is done in multiple centers where during the transition process, they have a day where the pediatrician is there, or the pediatric hematologist is there, and then the adult is there with them during that visit. So you get to meet both of them. Here at our center, we have tried, Dr. Mansour, I talked about it with Dr. Mansour and Ms. Jackie. So Dr. Mansour is our adult hematology oncologist. His program, his schedule has never been, you know, his schedule and Dr. Girudi's schedule are really not the best for them to meet. They've tried, but they always, the day he wants to meet is when Dr. Girudi is in Monroe, and the day Dr. Girudi can meet is when he's in Monroe. But we have things in place, you know. We have plans to get that process started here at our center.
These are real problems. You need, when you're the lone wolf howling on the hill, as I've been for a long time. You know you should do it, but there's just no way you can do it. And I know in our area, Dr. Chapter would be very interested in doing
that.
Internal medicine is, but you just need a little bit more in the way of bodies
And kind of what I see from my end as a hospitalist is we've actually currently got somebody in the hospital that's almost 18. He's going to see his, he's going to see his 18th birthday. He has a chronic disease, but the adult specialist won't come see him until his 18th birthday. Don't call him at 17,364. They won't come see him. It's got to be the 18th birthday. So how do you transition when we don't have the availability of the services to see them before they're 18?
I think what our hematology group is doing is what the other departments should start to do too. I mean, they are working on transitioning them sooner. Like in sickle cell, one of the things, once you get pregnant in sickle cell, you're gone. You don't stay in the pediatric team anymore. They transition you to adults because there are so many complications that come with pregnancy as a sickle cell patient. So I really think that with the other departments, they can start something. I don't know if it's if it's something the whole hospital can start. I was talking with Ms. Jackie. This transition process is a grand thing that's going on right now. We have like big centers that do not only take care of one subspecialty, they are looking at everyone in the hospital, the sickle cell, the GI patients, the diabetics, making sure that all of our patients get this transition. I pray that at some point we have that in our hospital too, where we have a team that looks at everybody and gets them ready.
It's much more essential and difficult. And I'm thinking back about 45 years now that I remember with one practitioner, some people talking, is when do people go from pediatric care to adult care? When I came here, the head of internal medicine made it very simple. When they're out of short pants, they're ready for the internist. But in practice, they told me, and this is true of my own kids, they go to the pediatric type until they go away to college, they get a job, or they get married and or pregnant. And that's usually the thing that changes them over. And when they're ready, I know my son went to his pediatric dentist until he finished his PhD program. But that's not the way a lot of people do it.
Yeah, so how many med students still go see their pediatrician? Have any of you not transitioned over yet? Did y'all transition in the last 2 years or so? There's usually one or two that's like, I guess I need to find a real doctor now. My pediatrician won't see me anymore.
So I think, I think because of what was going on in hematology with the development of this transition program, I think it's a really nice opportunity to kind of figure out, as part of that transition, what happens when a patient who's 17 and a half or 17 and 364 comes into the hospital. How can we co-manage that patient? And that might be one of the things that you consider as the program is being evolved. It's really, we're very happy that Tonjeh has decided to stay here as a Hemon Fellow, and that's going to help with this transition, and it's going to help in building this program. And so I think that's really in our favor to have her do that. So I think we have a great opportunity, and then from that could serve as a model for GI and for pulmonary and for other things where, and kidney, renal, and so we have great opportunities
Pulmonary
for
was a little bit easier.
building off of that.
Because
Yeah.
in the CF, you had a person who was
Right.
boarding with both adult and children, so it wasn't a big change, it was sort of
Right.
a moving over.
And that's another successful area, CF program. I think that's
Well, they've been fighting this battle. Actually, one of the first adults that got involved in the CF program was up at the bottom. And she became sort of a spark for the whole country to start getting people involved.
So this really serves as a really good reminder of how important it is to plan, to be organized, to work together, and primary care physicians are part of this as well.
Yeah.
And I think one of the things that Tonjeh mentioned that's really important is that even though some patients are seen in a subspecialty clinic, the line between who does the primary care, who does the subspecialty work, varies based on your population. Same thing happens in endocrine, and same sort of transition need to happen in endocrinology. And so this is a really important issue, and we've got 10 or 15% of the pediatric population as a chronic illness by the time they're in adolescence, and so this is a really important thing that needs to be on the minds of all primary care physicians as well as subspecialists. So, yes.
This is very important, and we have been discussing this in the major endocrine meetings. At least the last couple of years, there is always a major session on this, and I think it's very important for our patients, their well-being, their families also, for us as physicians to make sure that they are going in the right direction. So the question is, I believe for certain departments or divisions, it may be really important to set up their core transition teams, but of course, additional personnel, a dedicated RN, and probably the help of a social worker is needed because the insurance needs, etc. Also, the other question is, would it be helpful to consider a general committee for LSU, our Health Sciences Center, a transition committee, where there will be representatives from Peds, from several subspecialties, internal medicine, pediatrics. Maybe that might also create a general umbrella, and then additional work can be done under each subspecialty clinic. Also, never to forget for our young generation physicians here, we know adolescence is a special age group. Their brain maturation is not there yet, and that you may hear us talking about that with them and their parents, the need for supervision. And also after adolescence, now the new terminology is being used, emerging adulthood, rather than, we used to call them, and we still call them young adults or so, but emerging adulthood, you see this in the literature now. Some say ages 18 to 22, some say it may go up all the way up to 24 years. So again, that involves other transitions in life, going to college or getting a job, being self-sufficient in terms of finances. So I think, again, if it is found appropriate, perhaps a generalized committee, we can propose that, but I think as each subspecialty, we have to do our own little transition things, but maybe with some support.
Yeah. Your point about 10% get chronic disease. But all teenagers are crazy, so they got it. But the point is, the difficult ones are not the ones who have like mild intermittent asthma or occasional dermatitis. It's those who are acutely involved, and that's a much smaller group. And that's the one where I think we have and are going to have most of our severe efforts. The other ones can pretty well take care of themselves a little bit. I mean, we're forever telling them, you're going to be 21. I can't see you anymore. But remember, keep your appointments. Every time Kathy talked to them. Because if you don't keep your appointment, they may send you one more. If you don't keep that appointment, that you'll not hear from them again. And what do we do in pediatrics? You can say we're infantilizing them, but if we're not coming back, she gets on the phone and says, get your blood in here, we do have to see you. And there's two sides of that story. Are you infantilizing them, or are you just insisting they get it? But when it makes that acute transition, it becomes very traumatic at that time, because there's no warm pool to put them in before they go into the calidarium.
Well, that's an important point, because, I mean, essentially, as they become adults, they take responsibility for their care, as opposed to when they're young and their parents drag them in when they need to come. And so that is a part of this transition, is making the late adolescent, young adult understand how important it is for them to take control of their illness. And so that is part of the transition process. That's really a necessary component. All right, other comments? If not, thank you. This generated